Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 214 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, SOP, a 45-year-old man presents with acute unilateral vision loss. On fundoscopic examination, SOP has significant vitritis and retinal findings concerning for acute retinal necrosis. So my question to you is, what therapy should be administered in SOP's clinical scenario? Should it be A, acyclovir, or B, corticosteroids, or C, foscarnet, or D, ganciclovir? Or should it be E, penicillin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A, acyclovir. I will clarify why. Acute retinal necrosis is most often caused by varicella-zoster virus, and therapy with acyclovir should be administered. Corticosteroids may be used to decrease ocular inflammation, but should not be given until after antiviral therapy is initiated. Please advance to the next question. And the next question reads, CSI, a 26-year-old girl with HIV, not on therapy, presents to the comprehensive care clinic for her first visit. CSI has had several months of weight loss and intermittent night sweats. CSI has thrush. CSI also noted that she has had several weeks of visual changes with floaters and blurring of her vision bilaterally. Dilated fundoscopic exam was performed and CSI was found to have white perivascular retinal infiltrates and dot blot hemorrhages. So my question to you is, what is the most likely cause of CSI's findings? Is it A, Bartonellosis, or B, cytomegalovirus, or C, histoplasmosis, or D, syphilis, or is it E, toxoplasmosis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B, cytomegalovirus. And I will explain why. CMV is the most common ocular infection in HIV-positive patients. It is most common in patients who have CD4 counts below 50 per microliter, and patients often present with complaints of floaters and blurred vision. Examination shows necrotizing, full-thickness retinitis, often with some associated hemorrhage, which creates a brush fire or ketchup and cottage cheese appearance. Please proceed to the next question. And the next question reads, AJO, a 2-week-old infant is admitted to the neonatal ICU because of concern for sepsis. AJO's CSF profile is concerning for bacterial meningitis. So my question to you is, what is the most appropriate initial antibiotic regimen for AJO's clinical scenario? Is it A. cefotaxime plus acyclovir, or B. cefotaxime plus ampicillin, or C. ceftriaxone plus ampicillin, or D. vancomycin, or is it E. vancomycin plus ceftriaxone? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. cefotaxime plus ampicillin. I will clarify why. The most common causes of neonatal meningitis are Streptococcus agalactiae, Escherichia coli and Listeria monocytogenes. Recommended initial antibiotic therapy is cefotaxime plus ampicillin or an aminoglycoside. Ceftriaxone is typically avoided in neonates because of risk of kernicterus. Please progress to the next question. And the next question reads, WOP, a 65-year-old man with history of diabetes and alcohol abuse was admitted to the intensive care unit with altered mental status after having been found unresponsive. WOP is febrile and has depressed level of consciousness. WOP's chest radiograph shows a left lower lobe infiltrate and his head CT was normal. Lumbar puncture is undertaken and showed 568 nucleated cells with 97% polymorphonuclear leukocytes. CSF glucose was 20 and protein was 89. So my question to you is, what microorganism is the most likely cause of WOP's symptoms? Is it A. Listeria monocytogenes, or B. Neisseria meningitidis, or C. Staphylococcus aureus, or D. Streptococcus agalactiae, or is it E. Streptococcus pneumoniae? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is E. Streptococcus pneumoniae. I will explain why. Streptococcus pneumoniae is one of the most common causes of bacterial meningitis in adults and is particularly prevalent in patients with chronic illnesses, including diabetes, and alcoholism, and in the immunocompromised, including patients with HIV, asplenia, malignancy and those on immunosuppressive medications. Please proceed to the next question. And the next question reads, corticosteroid therapy is often recommended as adjunctive supportive therapy for adults with all but which of the following conditions? Is it A. meningococcal meningitis, or B. post-infectious encephalomyelitis, or C. streptococcus pneumoniae meningitis, or D. transverse myelitis? Or is it E. tuberculous meningitis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. meningococcal meningitis. I will explain why. Use of steroid therapy for bacterial meningitis, in adults, remains controversial because of methodological flaws and inconsistent results in the available studies. However, in the setting of pneumococcal meningitis, steroid therapy is recommended. Steroids also are recommended for patients with tuberculous meningitis and are often used as supportive care in patients with both transverse myelitis and post-infectious encephalomyelitis. Please progress to the next question. And the next question reads, GBY, a 50-year-old woman returned from California with fever and headache. GBY was found to have a thin-walled pulmonary cavitary lesion on her chest radiograph. GBY did not improve with treatment for bacterial pneumonia. Lumbar puncture was performed and CSF analysis showed 500 nucleated cells with 60% lymphocytes and 15% eosinophils. CSF protein was 150, and glucose was 20. So my question to you is, which of the pathogens listed below is the most likely cause of GBY's symptoms? Is it A. Angiostrongylis cantonensis, or B. coccidioides immitis, or C. Cryptococcus gattii, or D. Histoplasma capsulatum, or is it E. Mycobacterium tuberculosis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Coccidioides immitis. I will justify why. Coccidiomycosis is common in the southwest USA, Central and South America. CSF eosinophilia and pulmonary infection, as manifested by presence of a thin-walled pulmonary cavitary lesion and recent travel to an endemic area are suggestive. Please proceed to the next question. And the next question reads, ASM, a 35-year-old girl is admitted with her third episode of meningitis. ASM has been feeling poorly, with prominent headache, low-grade fevers and malaise for the last 3 days. CSF analysis showed 60 nucleated cells, with 70% lymphocytes. CSF glucose was normal, and protein was 62. The CSF results obtained from her previous admissions were similar to the current profile. So my question to you is, what is the most likely cause of ASM's meningitis? Is it A. Behçet's disease, or B. HSV1, or C. HSV2, or D. Neisseria meningitidis, or is it E. Streptococcus pneumoniae? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. HSV2. I will clarify why. This patient has mollarase, spelt as MOLLARET, or recurrent benign lymphocytic meningitis, which is most commonly caused by HSV2. Please proceed to the next question. And the next question reads, NTT, a 65-year-old woman presented with headache, agitation and delirium. NTT had a witnessed generalized seizure in the emergency department. NTT was started on anti-epileptic medication and head CT was performed to evaluate for stroke. NTT's head CT was within normal limits. NTT's brain MRI was later performed and it demonstrated bilateral temporal lobe enhancement. So my question to you is, what test would be most likely to prove the correct diagnosis in NTT's case? Would it be A. blood cultures, or B. CSF gram stain and culture, or C. CSF HSV PCR, or D. serum cryptococcal antigen, or would it be E. Streptococcus pneumoniae antigen testing? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. CSF HSV PCR. I will explain why. This patient likely has HSV1 encephalitis. Disproportionate enhancement of the temporal lobes, as demonstrated on her MRI, is characteristic. Behavioral abnormalities and new-onset seizures are also common. Please proceed to the next question. And the next question reads, PVA, a 55-year-old man is admitted, in the late summer, with several days of fever and headache, followed by altered mental status and progressive bilateral lower extremity weakness. On exam, he had flaccid paralysis of both legs, with some muscle fasciculations. PVA-SCSF analysis showed 450 nucleated cells with 75% lymphocytes, normal glucose and protein of 80. PVA-S brain MRI showed some T2-weighted abnormalities in his basal ganglia. So my question to you is, what type of virus is the most likely cause of PVA's symptoms? Is it A. bunyavirus, or B. enterovirus, or C. flavivirus, or D. herpes virus? Or is it E. polyomavirus? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. flavivirus. I will justify why. This patient most likely has infection with West Nile virus. He is presenting with meningoencephalitis with prominent peripheral neurologic sequelae. Other flaviviridae-associated diseases include St. Louis encephalitis virus, dengue, Japanese encephalitis virus and yellow fever virus. Please proceed to the next question. And the next question reads, KFS, a 37-year-old construction worker presented to the emergency department with fever and painful muscle spasms for 1 day. On examination, KFS's temperature is 38.1 degrees Celsius. His pulse is 122 beats per minute, and blood pressure 135 systolic 80 diastolic. He has a small wound on his hand with surrounding erythema and induration that he says he sustained because of puncturing his hand with a nail. So my question to you is, what is the first-line antimicrobial of choice to inhibit further toxin production contributing to KFS's illness? Is it A. clindamycin, or B. metronidazole, or C. penicillin, or D. tetracycline, or is it E. vancomycin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. metronidazole. I will clarify why. Treatment with metronidazole, along with tetanus immune globulin, should be administered. Metronidazole is recommended as first-line antimicrobial therapy for tetanus. The other antibiotics listed are recommended as second-line agents. Please proceed to the next question. And the next question reads, Estio, a 3-month-old baby was brought to the emergency department by her parents because of lethargy and irritability. Estio has not been eating well and has not had a bowel movement in several days. On examination, Estio has a depressed fontanelle and notably poor muscle tone and a weak sucking reflex. So my question to you is, how does the cause of Estio's illness appear under gram stain? Is it A. gram-negative bacilli, or B. gram-negative diplococci, or C. gram-positive bacilli, or D. gram-positive cocci in clusters? Or is it E. gram-positive cocci in pairs and chains? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Gram-positive bacilli. I will explain why. Clostridium botulinum is an anaerobic, gram-positive bacillus. This patient has infant botulism caused by toxin production from this organism. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 215.